Patna Centers for Obesity, Diabetes and Endocrinology, and he's having more than 15 peer-reviewed publications in national and international journals and has been a speaker and various national and state level endocrine CMEs with areas of interest being in GDM therapy, sarcopenia, diabetic nephropathy and adrenal insufficiency. Welcome, sir. I request you to start with the topic today, the topic being stepping up obesity care with semaglutide 2.4 mg. Over to you, sir.
Thank Endodiab for giving me this opportunity, and this is a Novo Nordisk sponsored talk, and conflict of interest is that I'm compensated for this talk actually, but then we'll be discussing some interesting science around obesity. Let's get on with it. So we used to think of obesity as due to voluntary excessive energy intake and decreased energy expenditure. So that's the impression that we all had actually. So far we used to think that people who are obese because they are eating too much and not exercising enough. That's the general impression that the general public has, and this carries on into the physician mode also. I think even to this day, I think many physicians do believe this, but the science around obesity has evolved over the last 10 to 20 years. We know that it's a chronic condition, it's a remitting, relapsing disease. Like, you can reduce your weight, but it comes back again. So the key aspect of obesity is that, it tends to bounce back again. Why it tends to bounce back is because it's got a genetic basis. Around 40 to 70% of the weight or a BMI excess that somebody has can be explained by their genes. So the rest of it is of course explained by their environment, but the environment is modifiable only to a certain extent. So though we can tell that you reduce your stress and do exercise, so this may work for a few months or few years, but over the period of time what happens is that patients stop doing that and then the weight regains. So many paths can lead to obesity. It's a complex interplay of several factors. For example, using a car and commuting actively using a car or a two-wheeler may increase weight for the individual. Whereas if they use a metro or if they use a bus or if they walk, then it may have a impact of say 1 to 2 kilogram in the same individual. So, but then our physical environment does have a role to play in the genesis of obesity, but that's not the only one. Not the only one. Our physical environment, how much we sleep, how much we are affected by stress, our emotional health also. So all this interplay is important for obesity. But the most important factor, the genetic factor, remains heretofore unaddressed. So we know that actually, but the genetic factor is unaddressed and we don't have a proper therapy for it. So that has changed with the new molecule what we have, semaglutide. So if you look at appetite itself, so it can be divided into 3 buckets actually. We eat for homeostatic eating. So because we feel hungry. So if you're not eaten for 7 to 8 hours, the homeostatic eating is what is required because your body asks for food because you're not eaten for food. But what prompts you to eat, you come to a conference today, you've had your breakfast and come in. So what prompts you to have a cup of coffee 2 hours later, whereas you had a good breakfast? What prompts you to eat is because probably the coffee is tasty or there is a social conditioning also. So we all come to a conference, everyone should step out and have a cup of coffee with friends. So that is a social conditioning, and also it's a more of a conditional, brain conditioning. So once you come to the conference, your brain will ask for the coffee actually. 10 gante agilva, like that, 10:30, half an hour over, 1 hour over, the brain asks for the food. So all of us are familiar with this feeling actually. It affects all of us. It's not unique to people, only with people who are obese actually. The people who become obese are probably unfortunate actually because they have got a very strong homeostatic hunger, they have got this conditioning also, and this is determined by genes. So how successful are lifestyle interventions? So we've been asking patients to do diet and exercise. So how successful they are? So it is reasonably successful. There is about 5% weight loss that you can achieve through conventional means by asking people to eat less, do exercise, and also behavioral intervention. So doing cognitive behavior therapy. So whatever I said you just now, whatever I told you just now, if you do it in the form of a one-to-one cognitive behavior therapy, it will not take too much time to make people understand, why they are eating. And many people do understand. And this works in about a good percentage of patients. So, but most individuals will regain more than half their weight loss within 2 years and more than 80% within 5 years. And that could be because of aging also. As people get older, their obesity gets worse. That could be the reason. So if you look at data which looks at prevalence of obesity through the age, so there is a peak at around, say, 35 to 45 years for men and above 40 years for women actually. This is a trend which we see in the population. So aging could also be the factor in the worsening of obesity. So, but after 60, 65 years, the BMI reduces because of muscle loss rather than because of fat loss. So, these are some of the important things. So weight gain, weight loss, this tug of war is going on forever. So, now we have Wegovy. So, Wegovy is nothing but a GLP-1 receptor agonist called Semaglutide, which is a 94% homology to GLP-1. And GLP-1, as you all know, is a intestinal hormone produced by the intestine, which works on the central nervous system and produces satiety after having had a meal actually. So it's produced by the intestine, works on the brain, reduces hunger and induces satiety. So direct activation of the hypothalamus occurs. Also, it has got an effect on the nucleus tractus solitarius, the vomiting region actually. So it induces directly activation of the hypothalamus and causes appetite suppression. It acts on the hindbrain and induces nausea. These are two different locations. So you may think that those who are getting more nausea may get more weight loss. That's not true. The effect on the hypothalamus is distinct from the effect on the hindbrain actually. The hindbrain activation causes nausea and the activation of the hypothalamus causes the appetite suppressant effect. So these two are distinct. It may be possible for someone to just have nausea and not lose any weight also. That is also possible. So GLP-1 receptor agonist works in key areas of the brain to help control hunger and cravings. So Wegovy increases satiety, making patients feel less hungry. So this is the homeostatic component. So if somebody is on Wegovy, so if they have had a breakfast, they will not feel naturally hungry. They can go without a meal for a longer time. So usual time of hunger is, say, maybe 1 o'clock. So they may probably manage till 4 o'clock if they are not having any access to food at all. Say, for example, they are on a long plane ride in Indigo where you have to buy food and all that, so then they avoid having food, then they can manage actually. So what is hedonic regulation? Wegovy 2.5 milligram reduces food cravings and preferences for certain foods actually. So one important aspect of the brain activation, brain conditioning is that we prefer certain kind of foods actually. So for example, I like to have at 4 o'clock always some tea and snacks every day. I love to have it. If I don't have it, I feel like my day is not complete actually. So that is a hedonic component of our appetite. All of us have it to some degree or the other. We can try to make it more healthier, but the healthy food does not give you the hedonic satisfaction actually. Only the unhealthy food gives you the hedonic satisfaction. So this hedonic craving also it reduces. It has been shown time and again in studies. So this is a set of trials which has been done for Wegovy. More than 26,000 participants. The step set of trials are focused on Wegovy as a weight loss drug actually, ramping it up to the highest tolerated dose where we look at only weight loss. And also on the left hand side you will see two panels. This is basically looking at the weight reduction or the fat reduction component. On the right hand side you see several patient important outcomes or clinically important outcomes. As doctors, we are worried that the patient should not get admitted to the hospital. They should live a long life. So does it reduce heart failure hospitalization? Does it reduce cardiovascular outcomes? Does it reduce food related outcomes? Does it reduce MASH related outcomes? So these are highlighted separately. You can see them in the separate. These are all outcome driven trials. I'll be talking about the SELECT trial today. So semaglutide has been extensively studied in more than 3,500 participants in India. So when you want to look at a molecule which has been studied in a lot of Indians, Wegovy will satisfy that criteria. Semaglutide, injectable semaglutide will satisfy that criteria. So let us look at the weight loss effect of Wegovy. So Wegovy, it's given in ramped up dosage. So usually the first month you give 0.25. Each pen, it comes in 5 different pens. 1, 2, 3, 4, 5 different pens. So each pen is used for a month. So you use it for weekly basis. So 0.25 milligram will give one dose every week for 4 weeks. And then after that, you'll have to discard the pen. So like that, 0.25, 0.5, 1, 1.7. you ramp it up based on tolerability. So all these were trials, the patients did not go to the highest dose. Not all of them went to the highest dose. So if the patient is not able to tolerate the higher dose, you stop there, okay, and and continue the drug actually. This was the intervention that was done. So 1,961 participants with obesity, more than 30 BMI or more than 27 kilogram per meter square with more than one comorbidity. This will probably apply to all our patients who will come in, almost 90% of patients who come in, and they were non-diabetic. So basically they had a stable body weight for 3 months. They were not rapidly losing weight or gaining weight already. So for example, hyperthyroidism and all patients may be losing weight. So those who had a stable body weight actually. So this was a trial that was done. Look at the reduction in body weight. There was a 16.9% reduction with Wegovy 2.5 milligram when compared to placebo. In the placebo arm, only the diet and exercise advice was given. So you can see that even in the placebo arm, there is a weight reduction. So it's not that the weight reduction is 0%, it's actually 2.4% in the placebo arm. So that's the average that was done in a clinical trial setting where you're giving good, dietary advice, exercise advice, etc. 2.5% lost weight. 2.5% is the average weight loss. Weight loss is 16.9% in the arm. And if you look at the number of people who lost more than 10%, this is very important data to me actually. So somebody who comes with say 60 kilogram weight, 6 kilogram weight they'll easily lose if they're having obesity. So, and how many people out of 100 will achieve this? 75% people. 3 out of 4 people will get a reduction of 10% body weight, which is an excellent result. So it's almost, very satisfactory when it comes to anybody. So if you look at larger degrees of weight loss, 15% and 20% weight loss, almost half of them lost more than 15% weight actually. This is a fantastic result when it comes to treatment of obesity. So the secondary endpoints include reduction in waist circumference, reduction in systolic blood pressure, and improvement in the SF36 function. So typically a 3-point increase is considered very satisfactory. So considering the fact that these patients were very healthy, and an SF36 improvement is very significant. So that's why we are probably not able to get a 3-point rise. So these were really healthy people otherwise. So they just had 27 kilogram per meter square and one other condition. It could have been hypertension or something like that. So these individuals are very healthy individuals. Already healthy individuals are improving their SF36 physical function score. The physically, functionally, they are getting better with time. So which is very good news. And secondary supportive endpoints were reduction in diastolic blood pressure and CRP. So what is the effect of maintaining Wegovy versus treatment withdrawal? So this is very interesting to note. It's a similar kind of trial where in one arm treatment was continued beyond 1 year, and on the other arm, the treatment was discontinued. So those who discontinued, they regained some of the weight, not all of the weight, but regained some of the weight. But if you continue beyond the run-in period of 20 weeks, up to 68 weeks, there was a 18.2% weight loss. So in a long period, the effect is sustained and there is progressive also. So in the previous trial, we saw that in 52 weeks, there is a 16 point something reduction. Here it is 18.2% reduction. So when you use it for a longer duration of 68 weeks, you get a further reduction in weight. So long-term maintenance over 2 years. So when you give it for a 2-year period, so key endpoints were, of course, change in body weight, those who lost more than 5% body weight, there is a 16.7% reduction in this trial. So multiple RCTs are corroborating the same thing. Around 16% weight loss we can get in people, non-diabetic patients with just obesity and obesity with a comorbidity. So what are the side effects? So this is the benefit. What is the side effect? What is the cost actually? So the cost is, it comes at a cost of some GI side effect. It's not very entirely a pleasant drug. So if you look at adverse events leading to discontinuation versus placebo, it's almost in the step 1 trial where it's compared to placebo, it is about 3%, it's double. 7% people discontinue the drug. And in step 4 and step 5 trial, lesser discontinuation rates were there, but it's in the ballpark of around 5%. So out of 100 patients for whom you will start this drug, around 5 of them will discontinue, telling that they are not able to manage the side effects at all. We should be ready for that eventuality. So gastrointestinal adverse events leading to discontinuation was the most common actually. So GI side effects are the number 1 reason for discontinuing the drug. There can be some other reasons also. The drug can be very effective and patients stop it because they lose too much weight. That has also happened in my practice. So increasing overweight leads to obesity and CV deaths actually. So CV mortality, so whereas CV mortality overall has reduced over the years. But if you look at people with obesity and their CV mortality and the obesity attributable CV mortality, it is actually increasing. So if you don't adequately counteract obesity, so you are going to have a increase in the CV outcomes due to obesity. So patient may not be smoking, may not be having high fat diet which increases LDL, maybe reducing stress, doing yoga, everything. But if you don't reduce their weight, they are going to have higher CV events because of the obesity itself. So we need to tackle obesity effectively. So far, when you look at conventional, heretofore used weight loss agents, their idea was to, reduce cardiovascular outcomes. So they actually dedicated cardiovascular outcome trials were done with Scout, Crescendo, Light, Convene, Camellia, etc. Let us look at the result. In the Scout trial, sibutramine increased the CV risk. In Crescendo, there was an early warning and it was stopped early. The naltrexone, bupropion, it was stopped early and interim data was leaked. Somehow it was, was stopped actually. Stopped early, drug ownership changed actually because it was commercially not viable. So non-inferiority was demonstrated, but the drug was withdrawn because of the increased signal of cancer actually with the lorcaserin. So they felt that the company have withdrawn it from the regulated markets. So these are the drugs that are available so far. None of them have shown consistent results as far as cardiovascular outcome is concerned. So in this scenario, SELECT comes actually. So SELECT is a study done on patients who have had a heart attack or a stroke recently, established CVD, or they must have some other form of established CVD. It can be peripheral vascular disease or documented coronary artery narrowing, etc. So age must be more than 45. No prior history of diabetes. These are non-diabetic CVD patient. Mind you, this is a diabetes drug, but we are using it in obese non-diabetic CVD patients. So who have already have a disease, and we are ramping up Wegovy like what I showed actually. So the primary endpoint was a time from randomization to the first occurrence of composite endpoint, non-fatal MI, non-fatal stroke, etc. So the people got lifestyle guidance, adequate medical treatment also. So there was a 20% reduction in major adverse cardiovascular endpoints. We are not here measuring only the weight. So we are looking at the reduction in the cardiovascular endpoints. We all know that MACE endpoints are the gold standard triple endpoint. Okay. So significantly reduce the risk of MACE. So over a period of 40 months. And you can see that the curves are diverging soon after study entry. So within 1 or 2 months itself, the curves are diverging. And the benefit keeps increasing as you give it for longer time. After 48 months, so you get a very meaningful reduction of 20%. So GLP-1 receptor agonist semaglutide should be considered in patients with overweight or obesity without diabetes to reduce CV mortality, MI or stroke. So this is the guidelines for ESC, okay, European Society of Cardiology guidelines. So it's actually entered the guidelines based on this, large outcome RCT. So again, SELECT is a trial which is a very large trial, which they included more than 17,000 subjects. So before maximal weight loss. So you can see many interesting things here. One is before the weight loss itself, the cardiovascular outcomes were reduced actually. And 80% of the MACE risk reduction Wegovy is mediated by factors other than body weight loss. So it may be something to do with the effect of reducing our eating behavior. So eating behavior is also maybe responsible for some of the MIs that are happening. So like when you go to a wedding, you eat continuously for 2 days, 3 days, that's actually probably more harmful. Maybe it is the eating behavior is being curbed, or in some way it is helping, or it may have, the GLP-1 may have a direct effect on the cardiovascular system as well, so which may be protecting the heart. So CV death was also reduced. Result was not statistically significant, but it suggests benefits from Wegovy 2.5 milligram. So there's 18% reduction in the risk of composite heart failure outcome, 19% reduction in the all-cause death in the Wegovy 2.4 milligram group versus placebo. So the all-cause death was not statistically significant, and the CV death was also not statistically significant. So Wegovy was associated with the reduction in multiple cardiometabolic risk factors. So the reduction in HSCRP, it reduces inflammation, it reduces weight, reduction in waist circumference. So this could also be another reason why the cardiovascular risk is reducing even though the weight is not reducing. So even before the weight could reduce, the cardiovascular risk is showing a lower trend, maybe because it cuts off inflammation immediately. Reduction in the systolic and diastolic blood pressure. So all these effects together are actually working when you give Wegovy. because multi-dimensional changes are happening in the individual. So key takeaway, one of the largest CVOTs with diverse population, Wegovy had a consistent beneficial effect and superiority is demonstrated. So practical aspects, how to use is that like this 0.25, 0.5, 1, 1.7 and 2.4 milligram. Thank you.
Thank you, Dr. Anantharaman, for a compelling talk on integrating semaglutide into clinical obesity practice. Your insights were timely and very well delivered. The dais is now open for discussion.
Thank you, sir, for that wonderful presentation. Are there any absolute contraindications for the usage of this medication?
Medullary thyroid carcinoma, personally, past history of medullary thyroid carcinoma, operated patient, we cannot use it. And if there is a familial history of medullary thyroid carcinoma also, we should not use it. That history we should ask for. Then pancreatitis patients, we probably should not use it. Though with GLP-1 as a class itself and also with this molecule, there is no excess occurrence of pancreatic events, pancreatic cancer or pancreatic this thing. So it's generally we do not use it in chronic pancreatitis patients actually.
Thank you, sir. Any questions from the floor?
And oral. So I'm not aware whether they have done a head-to-head trial. I think there are trials comparing the two. Efficacy-wise, in terms of weight loss, typically the injectable semaglutide would be better than oral semaglutide, sir. So, but as far as diabetes control is concerned, it is still 1 milligram Wegovy will be equal to 14 milligram of Ribelsus actually. But 2.5 milligram will give you better weight loss and better glycemic control in some individual cases because there's no option to increase the dose, no? So with the Ribelsus 14 milligram.
The weight loss that was achieved, was it different at different levels of initial weight or was it the standard, what we felt that there was 20% reduction or whatever the results? Was a higher weight loss achieved with higher weight to start off with or is there any cutoff like that?
It is presumably it is like that only because if you want to demonstrate 15% weight loss, I think those who are more obese will lose more weight, I think. So that's why it looks much better. So if you take 50 BMI patients, they will lose more weight because they have more to lose, right? So that's how it will be. But the thing is, the average weight loss is looking normal. I don't know the distribution of weights of the subjects included in the trial actually. So what tertile of weights were used actually. Yes. But it's a randomized, so both the sides were equal actually. So
thank you, sir. If there are no questions from the audience, I think we'll move to the, thank you, sir, for that wonderful presentation. We'll move to the next presentation.
Thank you.